Hello, and welcome to this presentation by the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled Managing Emergency Department Headache Patients, Life-Threatening Headaches and COVID-19 Implications. My name is Edward Sloan. I'm currently Medical Director of the Physician Assistant Studies Program at Dominican University, and I have been an attending physician in emergency medicine at Carle Foundation Hospital. I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. The content for this lecture comes in large part from the monograph titled Evaluation and Management of Life-Threatening Headaches in the Emergency Department by Dr. Zoda et al. It was published in Emergency Medicine Practice by EB Medicine, February 2019. Please refer to the complete video and audio content for this educational lecture, as well as other individual parts of this lecture via links found at FERNE.org. You may also refer to the initial podcast and the CME option on the EB Medicine website at ebmedicine.net and specifically at the link listed below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. In our discussion of neuroimaging for patients with headache and suspected life-threatening emergencies, it's helpful to talk about the ACEP, American College of Emergency Physicians, clinical policies that address acute headache. The first one was published in October 2008. It addressed headache in adults with 5 questions, and there were 3 levels of recommendations based on the strength of the evidence. Most recommendations are level B or C. Level A recommendations, which are sure that everyone should follow, don't require a clinical policy most often to be developed. It's in those areas where there's some uncertainty that clinical policies are developed, and those generate, for the most part, level B and C recommendations. So regarding emergent neuroimaging in adult patients with headache, level B recommendations include any patient with new abnormal findings in a neurological exam, including a focal deficit, altered mental status, altered cognitive function, should undergo emergent non-contrast head CT. And emergent studies are those essential for a timely decision regarding potentially life-threatening or severely disabling entities or headaches. Secondly, any new sudden onset severe headache should undergo an emergent head CT. So sudden severe headache, which might suggest subarachnoid hemorrhage, requires emergent neuroimaging. And any HIV positive patient with a new type of headache that they've never had before should be considered for an emergent neuroimaging study. A level C recommendation from this same question states that patients who are older than 50 years of age and presenting with a new type of headache, but with a normal neurological exam, should be considered for an urgent neuroimaging study. And urgent studies are those that are arranged prior to discharge from the emergency department with the appointment as part of the disposition, or performed prior to disposition when follow-up can't be assured. In general, in the United States, because of the availability of CT scan from the emergency department, most times this level C recommendation will become a recommendation for emergent CT scanning. So the most recent update of the clinical policy that was published in October 2019 by Drs. Godwin, Cherkas, Panagos, Shi, Binney, and Wolf has some new updates regarding questions with patients who present with headache. So this ACEP clinical policy, published in October 2019, again followed adults, and it had 4 questions. Again, 3 levels of recommendation based on the strength of evidence, knowing that most are going to be B or C recommendations, but there are a few level A recommendations. The first ACEP clinical policy question has to do with subarachnoid hemorrhage risk stratification. And it asks, in the adult ED patient presenting with acute headache, are there risk stratification strategies that reliably identify the need for emergent neuroimaging? This question generated a Level B recommendation that states the following. Clinicians should use the Ottawa Sub-Arachnoid hemorrhage rule as a decision rule that has high sensitivity to rule out subarachnoid hemorrhage because there are few false negatives, but it has a low specificity to rule in subarachnoid because the criteria generate many false positives. And using this for patients presenting to the ED with a normal neurological exam result and a peak headache severity within 1 hour of onset of pain symptoms, which suggests a sudden severe headache. What's in the Ottawa subarachnoid hemorrhage rule? The criteria that all need to be negative in order to rule out subarachnoid hemorrhage include age greater or equal to 40 years, complaint of neck pain or stiffness, witnessed loss of consciousness, onset with exertion, thunderclap headache, and limited neck flexion on examination. If all of these are negative, you can exclude subarachnoid hemorrhage. If any of them are positive, subarachnoid hemorrhage still must be considered. The other part of this Level B recommendation regarding subarachnoid hemorrhage risk stratification states the following. Although the presence of neck pain and stiffness on physical exam in the ED in patients with an acute headache is strongly associated with subarachnoid, do not use this or any other single physical sign or symptom to rule out subarachnoid. In other words, it's important to use the aggregate Ottawa subarachnoid hemorrhage tool and not any specific part. Another question from this ACEP policy asks the question about primary headache treatment. In brief, it says, in the adult ED patient treated for acute primary headache etiologies such as cluster, migraine, or tension headaches, are non-opioids preferred over opioid medications? And this did generate a Level A recommendation to preferentially use non-opioid medications in the treatment of acute primary headaches in ED patients. The ACEP clinical policy also asked about the utility of CT scanning, non-contrast CT, in subarachnoid hemorrhage within 6 hours. Here's the question. In the adult ED patient presenting with acute headache, does a normal non-contrast head CT scan performed within 6 hours of headache onset preclude the need for further diagnostic workup for subarachnoid hemorrhage? This is an important question for all emergency physicians and their patients. The Level B recommendation that generated states the following. Use a normal non-contrast head CT, minimum third-generation scanner, when performed within 6 hours of symptom onset in an ED headache patient with a normal neurological examination to rule out non-traumatic subarachnoid hemorrhage. In other words, a modern generation CT scan should be able to rule out subarachnoid hemorrhage in patients, even those with sudden severe headache, if performed within 6 hours of symptom onset. The last question from the ACEP clinical policy, published in 2019, addresses subarachnoid hemorrhage patients or those with suspected SAH and whether or not a CTA or LP is the preferred test to be performed following a non-contrast CT if there's still suspicion for SAH subarachnoid. Here's the question. In the adult ED patient who is still considered to be at risk for subarachnoid hemorrhage after a negative non-contrast head CT, is CTA of the head as effective as LP or lumbar puncture to safely rule out subarachnoid? This question generated a Level C recommendation that states, perform LP or CTA to safely rule out subarachnoid in the adult ED patient who is still considered to be at risk for subarachnoid hemorrhage after a negative non-contrast head CT. In other words, it doesn't have the strongest level of evidence support, but still there's a Level C recommendation to be considered, saying that you can do either a lumbar puncture or a CT angiogram of the brain. One last issue regarding neuroimaging in patients with headache. I just wanted to point out that optic nerve sheath ultrasound has been considered as a modality for addressing patients with acute headache. So, ocular ultrasonography can be used in patients with headache and suspected increased intracranial pressure. So, the sonogram looks at optic nerve sheath diameter. The normal optic nerve sheath diameter is up to 5 millimeters, and when on ultrasound this optic nerve diameter is greater than 5 millimeters, it does predict an intracranial pressure greater than 20 millimeters of mercury, which would be an increased intracranial pressure. And what it does is it acts as an bedside CT to help assess the possible presence of elevated intracranial pressure. When considering the diagnosis and treatment of emergency department headache patients, especially in the setting of this current COVID-19 pandemic, the following can be concluded. Emergency department headache patients who present with potential life threats can be identified. In order to do so, a systematic evaluation is critical, and the electronic medical record can help with this process. Most importantly, subarachnoid hemorrhage can be excluded in patients who present with sudden severe headache, given our current diagnostic capabilities. Also to be noted, head and neck infection, CNS infection, and CNS thrombosis must be considered if subarachnoid hemorrhage is excluded as the likely etiology for patients with potentially life-threatening headaches in the emergency department. During the time of this current COVID-19 pandemic, it is possible that common primary etiologies of headache, such as muscle tension headache, migraine, or even headache related to dehydration, can commonly be seen in emergency department patients. However, when considering patients with potentially life-threatening headache in the emergency department, at this time it is worthwhile to always consider COVID-19 as a potential etiology of these life-threatening headaches. During the time of this COVID-19 pandemic, besides specifically testing for the COVID-19 virus, there's no need to specifically alter our approach to diagnosing and treating patients in the emergency department with life-threatening headaches. If you have any specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you also to go to the fern.org website for more content related to this educational program, as well as other content related to the care of patients who present to the emergency department with life-threatening illness and injury related to neurological emergencies. Thank you.